Welcome everyone. Today we will be seeing phacoemulsification in patient who has undergone trabeculectomy and Ahmed glaucoma valve implantation due to secondary glaucoma post uveitis, and patient is also a steroid responder. Let's start with the case. First, we have to carefully choose the site of side port away from the Ahmed glaucoma valve and also little bit anterior to the bulb so that it does not disturb the bulb. Now, superior nasal side port has been made, followed by inferior nasal side port has been made without touching the Ahmed glaucoma valve. After this, air injection followed by tryptan blue followed by hydro wash done to perform the routine staining of the anterior capsule. After washing the dye, the recommended step is we should use cohesive viscoelastic during the capsulorhexis. For capsulorhexis, 26 gauge cystitome from superior nasal side port and iris repositor through the other side port is used to complete the anterior continuous collinear capsulorhexis. As we know, this was a case of steroid responder, indicating the patient was on multiple steroid for uveitis. The cataract which developed in this case was posterior subcapsular cataract. As we can see, capsulorhexis has been almost completed. So after completing the capsulorhexis, we will make a main entry on the temporal side with 2 mm keratome. Next, hydrodissection and hydrodelineation will be done. This is a case of secondary glaucoma due to uveitis, so there should be no or minimum handling of the uveal tissue during the surgery. Also, while doing the phacoemulsification, we should keep in mind that phaco probe should be opposite or away from the Ahmed glaucoma valve irrigation tube, as the nucleus pieces may obstruct the passage of the valve. For routine phacoemulsification, blunt chopper through the side port and 2 mm phaco probe of ortiliferous phaco is inserted through the main port. We are slowly and carefully removing the cataractous lens, keeping in the mind that phaco probe should be away or opposite from the Ahmed glaucoma valve, and minimum handling of uveal tissue should be there. We can also note there is a air bubble coming out of Ahmed glaucoma valve. Now, bimanual irrigation and aspiration is done to remove the cortex. Make sure no cortex or nucleus part remains or floats, as it may block the Ahmed glaucoma valve tube later on. Also, an utmost care should be taken while doing the irrigation and aspiration that the probe should be away from the Ahmed glaucoma valve. Now foldable posterior chamber intraocular lens implantation is being done under irrigation to prevent any visco going into the Ahmed glaucoma valve tube, which may occlude the tube later on. Just in case if there is any viscoelastic substance remaining, irrigation and aspiration is done to remove it. Now, as we can clearly see, the lens is well placed in the capsular bag and anterior chamber is well formed. Now routine closure of the wound by hydration of the side port followed by hydration of the main port is done, and the case is being successfully completed without. And we can also see that there is no damage to the Ahmed glaucoma valve. The take-away messages which we should have while operating with a patient with Ahmed glaucoma valve: aspirate the whole cortex to prevent the occlusion of Ahmed glaucoma valve device. Air bubble insertion is usually avoided, and always keep all the probes away from the Ahmed glaucoma device to prevent any damage causing to the Ahmed glaucoma valve. Thank you.